Okay, so welcome everyone, and thank you very much for joining us in today's EUHealthGov event. We are thrilled to welcome Dr. Mechthild Roos, Dr. Tamara Tubakovic, and Dr. Apostolos Veizis for an in-conversation event on forced migration and health in the EU. Before introducing our speakers, I want to introduce the context of this event just very briefly. For those who don't know us yet, EUHealthGov is a research network funded by the University Association for Contemporary European Studies and supported by the Erasmus Plus program of the European Union. The network is coordinated by Dr. Eleanor Brooks from the University of Edinburgh, Dr. Mary Guy from Liverpool John Moores University, and myself, Dr. Charlotte Godziewski from City University of London. And this event is part of our network's online quarterly seminar series. And these seminars have included in presentations of work in progress and recent publications, as well as roundtable discussions and practitioner perspectives and more. And you can find recordings and summaries of our past events on our website, EUHealthGov.org. So for today's event, we are honored and very excited to welcome our three wonderful speakers. Dr. Tamara Tubakovic. Tamara is a fellow in public policy and administration at the LSE in London. Her work specializes in understanding the institutional politics of EU asylum policy reform, the role of ideas and narratives in shaping asylum policy in Europe and Australia, and the role of the executive in the governance of migration. And before joining the LSE, she worked in public policy and European studies at the University of Warwick. And she also coordinated an Erasmus Plus Jean Monnet network called the Comparative Network on Refugee Externalization Policies at the University of Melbourne. Then we also have Dr. Mechthild Roos. Mechthild is a lecturer in comparative politics at the University of Augsburg in Germany. Her work looks, among other things, at the political regulation and the politicization of forced migrants' access to health and healthcare across Europe in times of crises. Mechthild's done a lot of work on EU social policy more generally as well. And I know that your recent book called The Parliamentary Roots of European Social Policy, Turning Talk into Power, has won this year the Science Award of the German Bundestag. So I just wanted to take the opportunity to sneak in my congratulations on this amazing achievement, Mechthild. And then last but not least, we are thrilled to welcome Dr. Apostolos Veizis, who is the Executive Director of INTERSOS in Greece. Apostolos has extensive experience in the field. Among many other roles, he worked as Director of Medical Operational Support Unit at the headquarters of Médecins Sans Frontières Greece. He was also the head of mission and medical coordinator for Médecins Sans Frontières and Médecins du Monde in a range of different countries, and worked as a consultant for the World Health Organization and the International Organization for Migration. So welcome to all three of you. It's really exciting to have you here. Today's focus is on the governance of forced migration and its impact on health and equity. And our speakers will discuss how policy reforms affect migrants' health, access to healthcare system, but also more broadly, how dominant asylum and migration paradigms affect well-being beyond healthcare. So for today, we're extremely grateful to have this wonderful panel. We would like to give each of you the opportunity to present for around 5 to 7 minutes, say. And we will then move to a conversation followed by an open Q&A with the audience. And just a note that the event is being recorded, and we would like to kindly ask the audience members to mute yourselves for now to avoid any disruption. Thank you very much. And yeah, Tamara, if you're okay to go first, the floor is yours.
Yeah, great. Well, thanks very much, Charlotte, for the introduction. When you first invited me to talk on this panel, as you recall, I was a bit surprised because I don't actually work on specifically health equity and health access. But then I thought about it a little bit more and realized that actually there's a lot here to be said about sort of EU governance and sort of, EU institutional developments. So in the brief 5 minutes that I have, I'm going to talk about three themes that are sort of very central to my own research on asylum policy making. So I'm going to talk firstly a little bit, or just sort of briefly mention the EU governance sort of infrastructure in the EU around this and the sort of limitations. And then I'm going to talk about I'm going to talk a bit about a concept called active neglect, which I think is really relevant to what we're seeing and how these sort of practices that we see and the sort of absence of healthcare can sort of be seen as an immigration control sort of structure. And then finally, I'm going to talk a little bit about COVID-19 and some of the sort of things that we saw coming out of that. So just to sort of start off with, I think it's really important to recognize the limits of the legal and institutional structures that determine asylum seekers' access to healthcare in sort of this multi-level structure of the EU and the issues that this then poses around sort of governing their access and also the accountability issues that arise. So the Common European Asylum System, which is what my PhD looked at, sets out common standards relating to asylum reception conditions, related to processing and qualification, and is really sort of the main legal framework in the EU in relation to asylum seekers once they enter the EU. And it is the recast conditions directive, reception conditions directive that determines or establishes minimum standards for access to healthcare for applicants of international protection in the EU during their asylum procedure. And it requires EU member states to ensure that asylum seekers at least receive emergency care and essential treatment for certain serious illnesses and mental disorders. So there is some provision there in the legal framework, but one of the main issues that we see is that the EU member states, and I think Mechthild will talk a bit more about this, is that the access to healthcare is a national competence. And while EU member states need to sort of ensure that asylum seekers receive at least sort of this minimum care, really the sort of provision of healthcare is determined at the national level. And because it relates to sort of social services, it is sort of, increasingly more politicized. And so, yeah, there are a number of different variances that we see, and there have been a number of studies that I think demonstrate that if you look at the different legal entitlements across EU countries, but also if you look within countries at different categories of migrants, the sort of main conclusions we see is that there is much fragmentation, much difference, and a lot of discrimination towards those who are displaced, especially asylum seekers, and those who are sort of undocumented. And so, yeah, we have this sort of situation where you have an EU level framework that, deals with a number of things, or tries to harmonize a number of things relating to the asylum process, but on key sort of healthcare issues, it's really quite lacking. There is a bit of a gap here. And there are a number of also issues when asylum seekers are trying to access healthcare provisions in these member states, relating to sort of administrative and language barriers, often a lack of information. Sometimes the treatment is not affordable, and often there's a fear of being reported or refused healthcare. And especially when we think about it in the EU context, where asylum seekers don't always want to seek asylum in the first country that they enter, and then they move to another country, this might then preclude them from being able to access healthcare because they're afraid of sort of coming in contact with a government service. So we have this sort of issue here, and then this also, of course, raises issues around accountability because, how can we sort of ensure that EU legislation is being sort of met at a minimum standard? So yeah, I think, just to sort of mention that I think these governance instruments that are there are sort of limited in the first instance. And then the second theme I just wanted to sort of mention is how healthcare or the absence of healthcare can be a strategic type of immigration control or type of instrument that governments use. And I think that the new closed controlled access centres in Greece are sort of a frightening test case for this. So these are EU-funded centres. They merged, they had the hotspot approach first, and then they emerged as a response to the failure of these initial hotspots, or to sort of try to improve them. And I think Apostolos will talk a bit more about this, but I think you can immediately see from their construction, from their operation, and in particular, their sort of geographically isolated positions. I think that this reveals a number of punitive and carceral features of these reception centres, where people are kept indefinitely, where they're kept under heavy fortification and surveillance, and access to healthcare provisions here is severely limited. There's lack of medical staff, lack of medical supplies, and I don't want to sort of get too much into this because I think, as I said, Apostolos will talk about it a bit more, but I think it's sort of worth thinking about sort of how we can conceptualize this. And I work a lot on Australia's immigration detention, and I think here there are a lot of parallels that we see, and I work a lot on policy diffusion as well. So I think there are a lot of sort of convergence in the instruments that are being used. But I think this concept of active neglect that one of my colleagues at the University of Melbourne developed is a really useful way of understanding what's going on here. So Claire Lachlan, she works on this idea that what we're seeing is not neglect, which is a sort of passive term, but an active neglect where the caregiver, so whether that is a government worker, nurse, doctor, caseworker, etc., is intentionally failing to meet obligations towards the care of that person. And we can see this where governments are systematically denying food or water or, just basic provisions, where they withdraw or cut medical services. I mean, in the case of PNG, refugees, when they closed the center, refugees were sort of just left there, forced out of detention centers with no follow-up provision. And so, they find themselves in a situation where they're homeless, or they, live in a country where there's sort of a lot of violence towards them. And so here, really, the argument that I'm trying to sort of say is that this routine harm can be seen as a way to achieve an outcome or goal of deterrence, right? So the idea is that we can make this so inhospitable that people will want to voluntarily leave and also deter others from coming. And then the final point is just to mention how health security discourses and perceptions of health risk are being or have been sort of used to inform new bordering logics, especially since COVID-19. So I worked on a collaborative project with a number of colleagues from criminology and sociology, where we looked at how in response to COVID-19, there were a number of public health orders that weren't directly targeting refugees, but which had a significant impact on them. So, we had COVID-19 passports, and we had restrictions on internal movements, which in particular affected the ability of vulnerable people who do not have official papers to be able to move around and access vaccination programs, or sort of, exacerbated existing health inequalities. And I think also during the pandemic, what we saw and what the project that I was part of looked at was how narratives of exclusion were sort of developed further, right? So what we really saw is how health security discourses informed societal perceptions of refugees as a threat. So often they were presented as sort of carriers of the virus who needed to be stopped at the border or quarantined to stop the spread of the disease to the wider community. And there was this increased use of, securitized language of, making references to a war against the virus, or the virus is the invisible enemy, the virus is a threat. And I think that this really sort of shows how, how relevant and how crucial policy narratives are that underpin government policy making. I don't think we should ever underestimate the power of ideas. And, really shows also how these narratives, and I think Christina Boswell works a lot on this as well, is how they're not really grounded in evidence, and they tend to perpetuate particular framings of refugees as a type of threat. And also just to sort of conclude that we can see how these narratives and policies can be seen as part of a long-standing sort of symbolic politics by governments, which is more about sort of responding to domestic interests. So, bordering and the, constructing borders and these narratives are not necessarily an effective public health response, but rather a political resource that governments can use to secure their reputation, to secure their electoral success, especially under conditions of, uncertainty and threat. So those are the three things that I just wanted to mention. Sorry if I spoke too long, but yeah, looking forward to the discussion.
Thank you so much. Thank you very much, Tamara. That was very, very interesting. I suggest to move on directly to the next speaker before, just to make sure for time purposes. Mechthild, would you mind going next, maybe, and then we'll move on to Apostolos afterwards. Thank you.
Yes, thank you very much. I'll just, because I did prepare it, try to share my screen. It doesn't work just yet. Voila, right now you should see yourselves. Do you now see the PowerPoint?
Yes.
Yes, perfect. Sorry, thanks. I don't see you anymore. I just see your PowerPoint.
Oh, right. So, okay. Yeah. No, it's all good.
Very much connecting and building on what Tamara just said, which I already have like questions I'd like to put to her myself. But yeah, I'd like to build on that and take it further from basically from the external borders of the EU really into the member states. which is what I'm focusing on in my research. And so there's basically this triad that I'm showing here that has in recent years shaped member states' responses to forced migrants' access to health and to health care. Health being, of course, much broader, as Tamara also already indicated, in terms of accommodation and access to all kinds of resources, both material and immaterial. And so there's these three elements I feel have been particularly impactful in recent years. So on the one hand, of course, we have the EU in a polycrisis mode, which puts member states supposedly permanently under strain and always asks the question of prioritizing in some sense, because there's always something urgent that needs to be addressed. And this question makes typically those lose out who are at the margins of society, so amongst others, forced migrants. And this is particularly true when it comes to access to health and healthcare, because we have this principle of help yourself before helping others, which means in politics, in EU politics and in member state politics, when it comes to healthcare and welfare, it's really the voters, the electorate, the EU citizens that are first taken into consideration, because, you know, it's a crisis, so we need to take care of our closest and nearest, and only then can we take care of the others. So we have this kind of principle informing governance the entire time, because there's always some kind of crisis going on, giving policymakers a reason to prioritize and to deprioritize those who are least important for their own positioning in the political game, in a way. Then Tamara also already mentioned, and Charlotte also, the issue of politicization, of increasing politicization of both health and migration simultaneously. For migration, this has, of course, been going on for a longer time. For health, this is not so very long ago that this started, but it's a clearly politicized issue by now, which makes it a focus of election campaigns, a focus of public discontent, although I put a little asterisk there, because at times it just seems to be the ones who scream the loudest who make it an item of public discourse. But nonetheless, this discourse suggests that it has an importance and a salience that makes policymakers react in those ways that Tamara already summarized so very nicely. And this, in turn, this combination of crisis mode, of national healthcare systems being under strain the entire time, of the next so-called migration crisis always being around the corner, leads to a race to the bottom, or has in recent years left a race to the bottom across Europe, across the European Union, often following the narrative of haven't we done enough? Argued by pretty much all kinds of member states. So the southern member states who argue we're receiving most people, so haven't we done enough in taking care that they are registered and that they're kind of, that they arrive in the EU, and then others should be responsible. And we have those self-declared moral superpowers, like, in my research, I'm focusing on Germany and Sweden at the moment, and both of them have established themselves as kind of moral superpowers who argue we have done so greatly in the past, for Sweden in the long-term past, for Germany in the short-term past, since the so-called migration crisis from 2015, 2016. So isn't it really now someone else's turn of letting them take care of forced migrants and giving them healthcare access and, providing for the resources that are needed. So again, we have this race to the bottom to ever more restrictive healthcare access in national legislation across the EU, kind of as an EU trend, which also makes us maybe gives an answer to the question, who is the EU when it comes to the EU and forced migrants healthcare? That is clearly the national governments, of course. We have, of course, the European Health Union, or the idea and the plan of the European Health Union. This health union does not include forced migrants. It's clearly not meant to apply to those without a non-temporary permanent protection status. So these are clearly left outside, even within Europe. So even within a society, they are still left outside when it comes to political planning for better health, more sustainable healthcare, public health improvement, etc. So they are not really part of the game unless they are considered, as Tamara also already pointed at, as a health threat. but then they're in some sense dehumanized and just becoming an issue in a sense that might need to be solved by better vaccination rates or by more general screening or these kind of things, which in my opinion do not deserve to be called healthcare access or health access, because that's not really the idea behind this. We have in national legislation on forced migrants healthcare access an increasing intensity of references to European Union legislation, but these are just two that I gave you here. These are among the directives that have some impact of how forced migrants healthcare access is regulated at the EU level, at the national level. But it's important to keep in mind that they are directives, so they give the member states a lot of room of maneuver for how to interpret them, and there results this fragmentation and diversity and discrimination that Tamara already spoke about when it comes to how exactly national regulators regulate forced migrants healthcare access. On the other hand, we do have an increasing kind of role construction of the EU in national healthcare for forced migrants that is kind of detached from what EU legislation actually does. So we have in national legislation an increasing trend towards blame shifting to the European Union for measures that are potentially unpopular among their own electorate, or also for measures that are potentially controversial because, for example, because an EU directive allows for forced migrants without permanent protection status to be treated differently when it comes to healthcare access. And so, you know, a party can say, yeah, okay, that's not really our line, but we're just abiding to EU law, which of course is controversial to say the least, because they could interpret these directives in a different way. But again, they are used as kind of a justification basis to implement certain restrictive measures. We certainly also have another level of horizontal EU references, which is responsibility shifting to other member states. So when it comes to, for example, migrants who have entered the EU in another member state or who are supposed to be moved, relocated to another member state, then that gives member states a reason to argue in their own legislation that they have the right to treat these forced migrants less generously than permanent members of society, because, you know, in a sense of they are not our business. Following this kind of narrative that we have this horizontal EU level among member states, that they're kind of responsibility shifting amongst each other. And also very clearly, we have this comparison to other member states, again, this narrative of, but we have done so much already. And if we stand out as particularly generous, we're just going to be a target country for ever more forced migrants, which is of course untrue. This has been shown in a large and growing number of studies, that this argument just doesn't work, this pull factor just doesn't work, but it's still very prominent in national discourses on the regulation of forced migrants healthcare. Just so much for my input. Thank you very much, and I will stop screen sharing again.
Okay, great. Thank you so much, Mechthild. That was a very, very interesting presentation, very insightful. Okay, so let's move on maybe to Apostolos.
Yeah.
Okay, I think you also wanted, did you have some slides that you wanted to share?
Yes, I did. I do have some slides. So let me try to do the sharing of that. Give me a second. Here we are.
Is it available already, or?
I have it available, but the just me.
Okay.
Do you see my slides now? No.
Not yet.
No, not yet. Now I think you see them.
I think something's kind of.
Yes.
Is it just me who doesn't see them yet, or? Ah, yes, perfect. Okay, great. Thanks.
You can see them.
Okay. Yes.
Good. So in that case, I will be very quickly, because we need to have a bit of a discussion regarding the EU governance and forced migration impact on health and equity. So these are the pictures of the, few years before the end of the Second World War, and the pictures on the right are the camps of closed control centers in Europe. And of course, what we've been seeing the last year as organizations or as field workers, we've been seeing the consequences on the physical health and mental health, be that lack of discrimination, access to healthcare, the violence and violation of human rights, torture and ill treatment, also interruption of chronic treatment, including correlation between substandard living condition diseases. And this has been very clearly from restrictive policies that have been implemented by European Union as a decision of deterrence, poor reception condition, detention as deterrence, externalization of the borders, active forced voluntary return, pushbacks and push out or push over to other European countries, plus readmission agreements. So in reality, we did not treat people based on their medical conditions of microbes and viruses, but as impact of those restrictive policies. And I think it's important to understand health. It's a definition that from 1946 has not changed. It's a state of complete physical, mental health and well-being. And when you talk about public health, also it is a science of preventing diseases and prolonging life of people through organized efforts of the society. But unfortunately, the health and public health have a different notion for people on the move. In addition to, as we talk about health of people, when you talk about mortality, 60,000 people have been losing their life since 2014, with majority of them in Mediterranean Sea becoming a wet graveyard. And of course, here you can see in a welcoming picture from one of the hotspots in Greece in 2015. This is the welcoming of people. And I continue a bit on the story how people have been welcomed in general in European settings. And as I mentioned again, health, it's a state of physical health, mental health, and the well-being of people. ECDC in 2011 mentioned very clearly that the risk for communicable diseases in detention centers is mainly linked to overcrowding, lack of hygiene and basic supplies, and not necessarily to people bringing diseases. So you can see that 63% of the medical conditions were related directly to the substandard detention conditions, including the mental health symptoms from anxiety to depression to PTSD and to self-harm for those people. And of course, where people are on the move, you find them in different locations. And if you put lights on, you can see them. And if you remove the lights, you don't see them. And you can see that people arriving when they're on the move, the main medical condition they have, their respiratory tract infection and trauma. Respiratory tract infection, as the journey continues further, are increasing due to the fact that they're exposed to weather conditions. The same with trauma when they have to go to cross borders, rivers, and et cetera, et cetera. They don't see any infectious disease among those conditions. What we've been documenting systematically is self-reported intentional violence from the state authorities, from community and smugglers, including physical violence, ill treatment, and sexual violence from the authority side. Mental health conditions, so people on the move when first arrive in the European Union, they have mainly anxiety, but you'll see later on that this anxiety changes quite differently afterwards based on what the people's situation are facing about. So the biggest, let's say, challenge in Europe was the EU-Turkey statement or EU-Turkey deal of 2016. And I know the first time I heard deal about for humans, I knew about deals about potatoes and aubergines, but never about human beings. So the country became a mushroom of camps on the island and camps on the mainland, where we documented as at that time together, and this is published also as a paper, that the violence on the state-managed facility was even more than the violence that people have been facing on their countries of origin or during their journey. So these were the camps. So there were people were placed by the side of the authorities. So theoretically, these are the breeding places for diseases. So whatever the best doctors of the world, you bring them there. I think the reality it is sad. So this is the pictures of reality that people have been facing. And I continue with that. So WHO in 2018 produced a report regarding the health of the people in the European region of migrants and refugees. At the same time in 2022 about health of migrants and refugees. And the outcomes of the report is that refugees and migrants are generally in good health, so they don't bring diseases. But of course, they are falling sick in transition because of the poor living conditions, inadequate food and water, increased stress, and lack of integration. So in a way, they come healthy and we make them sick, and then you need to treat them. That's another challenge you need to face. Mental health situation, living conditions in the camp, lack of legal information, uncertainty about the future, the feeling of insecurity, the isolation, discrimination, and destruction of family identity creates a lot of mental health situation for the people. And you can see here that after the people were put on those camps, we have an increase of PTSD, depression, and also self-harm from the side of people. Main morbidity we've been treating, skin conditions, respiratory tract infection, trauma. So it's related purely clearly with the living conditions that people have been living in the camps. And you can see here also that if there are medical people around, and you can see that the number of diseases are purely clearly related to the living conditions of those people. During COVID time, we were going to the supermarket and you had a specific number and a specific number of people could enter. That refugee camp, how they looked about. So you had an overcrowding. And then, of course, we analyzed the data, and this is published also on the Lancet, where the impact of COVID on population living on the Greek islands, there were 3 times more than the general population, and refugees living on the open refugee facilities on the mainland, 2.5 times more COVID among those people than the general population. Now, the response that is being done these days is the response of putting fences, pushing people back, putting walls so we don't see them or make them invisible, and of course, creating the so-called close control access centers. They don't look different from Guantanamo, so there are prisons, electronical and camera monitored. They have a lot of medical equipment inside, but they don't doctors and nurses to work with those equipment. So if you want to visit those places as a zoo, they can show you that there is a medical clinic, but that no service is being available. And on those centers, we have been seeing depression, anxiety, and PTSD as the main symptoms. So those facilities, the close control centers, are producing those type of medical conditions, including violence, including sexual and gender-based violence for boys, girls, women, and men. Even though they are managed by the state with cameras and being controlled, the violence is ongoing at the moment. And this is documented from our side. Now, going a bit on the challenging and proposals, why we see this situation in the country? We see the situation in the country because there is lack of political will in Europe. There is lack of coordination. There is no linking of NGO health services to the national health systems. There are a lot of barriers administratively and political barriers. There is no capacity building for the human health resources. There is no interest on sharing the good practices and developing a public sector on dealing with displacement issues. And of course, all those things can be solved if there is integration of the people. If they are integrated, this is also something that can be sustainable for all of us. So that's why it's important through those webinars, we are exposing the medical and humanitarian consequences of restrictive migration and asylum policies and exposing inadequate state response. And I think it's important to promote models of care and innovation, and also promote humanitarian approach, so humans versus the legal status. And of course, it's important to speak out, because I think one of the issues that we face worldwide is that we are being quite a lot of indifferent. Of course, there are limits and challenges. Media fatigue, we are focusing on the consequences without giving a solution. But of course, we know what solution can be. It's complex and repetitive messages. Public order discourse and security of people, Islam and all this stuff are being beyond the needs of the human being. And of course, it's a low profile approach, making advocacy limited in some type of situation. So for me, those camps that the European Union considers as the model are the human rights graveyard. And this is a picture from Moria afterwards. And something closing my presentation, would like to remind everybody that the refugee crisis is not about refugees. It is about us. Thank you very much. Floor over to you.
Thank you so much, Apostolos. That was a very, very insightful presentation. Very depressing to see the bleak reality of that. Thank you to all 3 speakers. I do have some comments and questions prepared for discussion, but first, I just wanted to hand over to you 3 and ask you. If perhaps you wanted to react to each other's presentation, or if you had questions for each other before we also open up to questions from the audience. Oh, perfect. Yes, Tamara.
Hi. Yeah. I have a question for both of you. No pressure. My question to Apostolos, I was just wondering what role NGOs play in sort of perhaps, replacing certain government functions. Is there what do they kind of do in these reception centers, and what does that sort of mean broadly for governance? And then for Mechthild, I'm sort of interested. You mentioned about the directives and how so directives are then member states have the flexibility to implement it as you wish. And I don't know if you know much about the recent reforms and how this is sort of trying to introduce regulations instead of directives. And whether you think this new legislation or new reform, what is that going to mean then for the governance at a national level?
So very quickly on your question. So theoretically, the different European states have been taking more and more steps saying that they don't need any NGOs anymore because they can cover themselves and they have the resources to do so. In reality, that's not the case. So the state, it's not they don't have the money or they don't have the resources, they don't have the will to deal with the issue. And secondly, for me, the isolation, you don't need to put people in the camp. That doesn't mean that you don't need reception centers. You can have reception centers, but you don't need to include people in the camps, because the camps themselves, by definition, historically and etc., are made in generally as an emergency response to a situation. So in a way, this is not, and of course, especially this idea of maintaining these camps far away from everybody, not to disturb the life of people, this is something that is creating a lot of problematics. Now, the NGOs, they try from one side to provide services, but on the other side, the challenge is about how far you can speak out. And NGOs, if they are fund depending from the governments, it's very difficult for them to speak out. And for me, I disagree in general to provide service without speaking out, because the idea is I'm not there to replace the state. It is, I can replace, I can be next to the state to help them with the know-how. But I think now, after so many years, there is the knowledge around. So what do you need? You need to have proper living conditions. And I think, you know, discussing about proper living condition, I think this is not an issue in Europe at the moment. I mean, it's a matter of the will. And if you use, let's say, bad living conditions as deterrence factor, I mean, you are wrong on that position. Secondly, you put the resources needed. And I think by definition, if people, they know a roadmap, now you guys know that, for example, in a few minutes, we're going to end the webinar. So I'm going a rushing way. But if people wake up every morning and they don't know what is going to happen with their life, of course, their mental health condition is being destroyed. So there are a lot of NGOs. It is important to base and face and challenge the governments about their responsibilities. But then it's limited, because you have NGOs being accused about being human rights or human lefts. We are being accused at the moment there were smugglers partners. We are being accused there we are Turkey partners, and we work together with the Turkey in order to destroy European elements. So this is something that today, for example, in Greece, it's a shame saying that you are working for an NGO, because you know you're being perceived as a smuggler. So we have been seeing systematically criminalization from European states of migrants and refugees, considering them as, you know, as a threat, as a security issue. And the most important part, closing my answer, is that they are considering that NGO are not, they are part of smuggling network. NGOs are good when they replace the government, but as far as they're being a pain in the back for the government, they're the smuggling network. Thank you.
So to answer your question, and then I also have questions back, if that's okay. It's really interesting and depressing at the same time, I fear, to see the ongoing debate and discussion about how to make the EU asylum system more enforcing and enforceable. Everything that I've seen so far just concerns, when it comes to using regulations rather than directives, just concerns the external borders of the EU, but not so much the situation of forced migrants within the societies, or well, at the fringes of the societies, really. So the only thing, what I've seen so far in this new package of new asylum and migration governance is pretty much the manifestation of a permanent crisis mode. So it's so much emphasized in there that given the situation and given these strains on all kinds of ends that member states are facing, it's very important that they remain able to react very quickly to threats against, and then you can list all kinds of things. So I fear the only effect this is going to have is to put even more oil into the fire of this race to the bottom, because again, it manifests this permanent crisis mode, and it manifests the situation of yeah, these are just exceptional measures that we have to take because we're so overwhelmed, instead of setting minimum standards that are even remotely acceptable. Again, according to everything I've seen so far, this is still in progress, but the progress doesn't make me very hopeful at the moment. And I have, Tamara, to you, I think I already reacted in my own presentation, so I don't want to take too much time away from the audience, but I had one question to Apostolos, if I may. You mentioned the role of the national healthcare systems, and you mentioned that even if there are facilities in the reception centers, that there's nobody there to use them and to help people. And I was wondering if you have, what your impression is from the side of the national healthcare systems, of healthcare providers. Would they be open and willing to? So is it only the political side stopping this, or do we also have some kind of hesitation on the side of the healthcare providers? Because I'm asking because I know from the kind of northwestern European countries that when member states leave it open to practitioners to decide on access, which some of them do, then practitioners at times become so insecure in terms of, for example, if they personally have to pay for treatment because yeah, the system might not allow for certain healthcare access for forced migrants. So they risk basically having to pay out of their own pockets if they treat someone. If we have this also in a sense for the reception centers, or if you rather say, yeah, the national healthcare systems there would like to pitch in kind of to prevent the outbreaks of larger problems, the creation of healthcare problems. I think I really liked the way you show that, like we create healthcare problems, we don't import them. Yeah, what their position is.
Yeah. Well, I mean, very, very, very quickly, because we need another webinar to discuss about it. But so the point of view is the following. The constitutions of my country, at least, or in Europe, they're saying that everybody living in the territory of the country is entitled of healthcare. Full stop. Secondly, we have a legislation who says migrants and refugees only for emergencies. Then access is not for everybody. Third, until 2019, everybody had access to healthcare. I'm not talking about accessibility, quality of care, etc. In 2019, the government decided that asylum seekers, they will have a temporary access to healthcare. And if the asylum seeker request is being cancelled, then they don't have access to healthcare. So if you are pregnant, you have to stop your pregnancy. If you have diabetes, you have to stop your diabetes because your asylum it's linked with that. So the point of view is that the governments theoretically have responsibility for the citizens and the people living in the territory of the country. They guide the process. If the doctors, first of all, starting from medical students, nurses, and midwives, need to be trained how to work and with refugees, need to be trained how to work with intercultural mediator. You need to make those resources available. So in the hospital, you have an intercultural mediator who speaks Arabic, Farsi, whatever. So I'm a doctor, and if you come tomorrow, and I'm willing to help you, but I don't understand what you're talking to me. First. Secondly, you need to make resources available. The question at the moment is that for every country, theoretically, you have a population in Greece as we have 11 million people. You have, let's say, an extra 1 million refugees, and definitely you need extra resources for those people. So if you want to make those calculations, what would be the needs for treatment? You have a general picture of morbidities and mortality situation. What are medical conditions we are created? In reality, if you make those calculations, you can go to European Union and say, I have an extra million patients, and I need to offer those people this type of treatment. The question is that in 2015, Greece got 3.3 billion euros until 2020. And this money was not used for the needs of the people. So the reality today at the moment is that if you present those people as numbers, if you present those people as a, put them in a camp and then maybe we can send an NGO, we can give some money here and there. The healthcare staff in general is not against them, because when I refer them to Charlotte or to Tamara and sending them a patient, they're okay, they have the patient. None of the doctors says no to that. None of administrative staff. They are afraid because of the legal frame put in place. So the administrative staff, if the patient doesn't have a paper, you send him away. So in a way, there is, of course, a lot of situation of inequalities also in my country. Imagine, for example, that if you have an island of Lesbos with 30,000 people and you have 30,000 refugees in a second island, and if there is only one surgeon available, of course, this is not for everybody. So the question is, you need to address in a country both inequalities for your people and the refugees and migrants. So I'm not saying that, take one and leave the others. But again, concluding it, I have to tell you that the health economics, if you want to talk about health economics, by creating more medical problems, at the end of the story, you need to treat them. And you need to put extra monies and resources. So you need to think a bit wise on that. If you think that you punish people because they made a mistake to cross the borders and all this stuff, you just make a mistake. And I think the way is that this is being presented to the people as a burden. These people are here and all this stuff. And on the other side, Europe is crying those days for hands. They want hands of people because they don't have people to clean, people to collect olives and blah, 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 and all this stuff. So I think at the moment, what we miss as an academic community and an NGO community, we miss one voice, not for converted people, because I think most of the people on the webinar are converted, all of them. We don't need to convince each other. We need to go beyond the scheme and explain to our communities gradually and we don't have to tell them the refugees and migrants are good people. No, they're not good people. They're just people. They are not looking for a better life. They're looking for life. That is different. People, they think they're coming for a better life. No, they're looking for life. And especially if you have to leave, majority of the people are coming from Palestine, coming from Afghanistan, from Syria, from Yemen, and all this stuff. So this is not, and this idea of people, not having not being refugees and there are people coming of countries where there's no war. This is also, so my French, it's a bullshit. So I think it's a matter that we need to inform people gradually, but there's no much of voice. Media is controlled. My mother doesn't want to listen anymore to this because she's facing financial crisis. She doesn't have firewoods to warm herself. She said, don't talk to me, tell it to Charlotte, because she's coming from a rich country and they have money enough. We are a poor country in crisis. So I think it is a complex issue. But answering to your question, I think the healthcare staff could be part of your move if you need to mobilize them in a proper way, because there is a bit of let's say, indifference in general, because everybody's thinking about his individual window. Over to you.
Thank you so much. Thank you for this really interesting conversation. I mean, I don't want to interrupt if you still want to add additional questions to each other, but I also want to really open up to the audience already, because I see mindful of the time. So if people want to pop questions in the chat or raise your hands, and we can allow the mic and camera if you want to jump in. But yeah, otherwise I don't want to use up too much time, but I guess I had one question, which was also about the sort of the multi-levelness of governance. And when I was listening to your presentation and also reading some of your work, what I found really compelling with this active neglect is how the state fundamentally operates in a very exclusionary way, whether that's excluding with external border or excluding in the welfare system. It's always about creating insiders and outsiders. And so, meanwhile, it seems that maybe some more progressive policy responses might be coming from municipalities or cities. And in health policy, we talk about like policy space in terms of like how much capability these sorts of governance levels have in implementing and coming up with policies. And so, I guess my question was, in a place, for example, like Greece or Germany or any other European country, what do you think? Do you think we can turn to like municipalities and subnational levels for progressive answers, or I can see Apostolos already not very convinced by this point.
Listen, why I'm not very convinced, and just to be very short on that. I think we need to call the state to keep us the responsibility. Municipality, NGOs, everybody else can do whatever needs to do, but we are not here to do the state work. The governments a few years ago decided to have the so-called corporate responsibility. Coca-Cola is building kindergarten, I don't know, Pfizer is building roads and all this stuff. This is not their responsibility. They're not doing it they're not doing it because they love us. They do it for business. So I think at the moment, this is a state responsibility. We need to make them accountable. How many European citizens ask, let's say, European Union, why did you spend 560 million euros to build up all these facilities for producing diseases or keeping people in prisons? Did anybody make accountable? No. How many European citizens make accountable European states? Why did you pay millions and billions to Pfizer and Moderna for the vaccine? No, because at the end of the story, this is not people they consider it's not their money. It's their money. They don't understand it. So I think what we need to wake up people is that they need to be responsible for themselves. They need to raise their voice and make accountable their municipalities. They make accountable their governments. They make accountable the European Union. Elections are coming soon. The problem is that the people, they think that these governments are just a virtual thing, and this government then take measures every day, even stronger. The quality of life is going worse and worse for the local community, including migrants and refugees, and people are just silent. So everybody is very happy looking at social media, if Kim Kardashian is wearing tonight or not wearing what type of shoes or trousers, or if the football match can take place. I think we are not anymore responsible citizens. We need to be citizen responsible, because at the moment of the story, when I go and speak to the media and I speak in this type of events, people, they think, well, I mean, these guys are working for an NGO, these NGOs are just blah, blah, blah. No, we are responding, we can give solutions, we can tell you what to do, and etc. So, I mean, we can help also with the idea, but it is not the role of municipality. Yes, you can use sometimes municipalities and others to put pressure on the government, but the idea of taking responsibility, government would be very happy with that, saying, very good, this municipality, and they will say, congratulations, municipality. No, it is state responsibility, and European Union is responsible. And also, European Union, we need to ask European Union to stop, sorry again for my French, to bullshit, saying that it's a member state responsibility. This is not true. When they want to pass something, they push the member states to implement what they want to do. They blackmail Orban to pass whatever they want. So when they want to blackmail somebody, they want to blackmail. Otherwise, they say, well, we give them guidelines, but then it's a state responsibility. We give them money. No, I think it's important. We need to change the way of thinking, acting, and working.
Yeah, thank you. Yeah. Oh, Tamara, you wanted to react?
Yes. So I just want to say that that was exactly my immediate reaction, this idea of responsibility shifting, which I think is problematic because it allows governments to evade their accountability. And we see that, how they shifted to the private sector, et cetera. But I did actually think, as I was sort of thinking this in the Australian context, I mean, in fact, there are actually groups or communities of people that do support refugees and who do sort of want to have some say in this. And I was just sort of thinking, I mean, I don't necessarily know how it would sort of work out in terms of, you know, how they would sort of govern this. But it just made me think that, you know, perhaps there could be a sort of bottom-up accountability. So if you do empower sort of the lower level municipalities or, you know, cities that we have in Australia, whether that could sort of feed back up. But I do know that, yeah, there has been a lot of mobilizing at this local level in support to provide these services that the government is actively choosing not to provide. And, you know, a lot of sort of legal mobilization to support them where there are sort of, you know, these functions are lacking. But I do agree that it shouldn't necessarily always be the responsibility at this level, because that you know, the state can then just, you know, wipe its hands clean and say, you know, yeah, you take care of this. But yeah, I just wanted to add that.
Yeah, great. Thank you, Tamara. Yes, Mechthild.
Very much, yeah, going in the same direction as the two others. My immediate thought was also, it's basically a question of generosity versus rights. So a municipality can never establish rights. That's something for the overall polity to do. So that's either the member state or even the EU who needs to do this. And so this responsibility has to lie with the state. Healthcare cannot be something provided out of generosity. This has to be the human right that it is. I mean, as Apostolos outlined very clearly. So yeah, really, it's in terms of duties and generosity. But then again, coming from a member state that is a federal system and that builds very strongly on subsidiarity, there is, of course, a noteworthy role for municipalities to play when it comes to implementation. So this depends obviously very much on the system. If you have a centralized healthcare system, or if you have a system that builds on decentralized provision of healthcare and of health and of access to resources and access to accommodation and all the things we talked about. But then again, this can only be about the implementation. This cannot be about the rule setting. This needs to remain in the hands of the state, I would also absolutely say. Especially also since at the moment, the national level, of course, looks to the communities in a sense and says, yeah, okay, if you can do more, we're really grateful to you, and we praise those that do something more. But at the same time, national level politicians and EU level politicians give municipalities the excuse on a silver platter to say, oh, we're so overwhelmed with everything. So if the national level is already saying this, what are the municipalities supposed to say? So again, in this way of thinking, it really, the minimum standards need to come from the national level, and these minimum standards need to be at a level that really has something to do with health and with proper healthcare access and healthcare provision. And this is also my very brief answer to the question of Ellie in the chat to me. If there would be one thing the EU could do right now, what would I want it to be? Minimum standards. That's, I think, the one thing where the EU has been quite successful when it comes to its own citizens, whenever there is healthcare welfare at stake. And so implementable minimum standards. Right now, there are minimum standards that are these formulations of everyone has a right to health and everyone has a right to physical and mental, the highest attainable standard, the highest attainable degree of physical and mental health. But what exactly that means, that is entirely unclear. And so this, I think, needs to put into concrete legal letters in a sense. So yeah, that would be my answer.
Thank you very much. Thank you all three. There is one hand up from Eva. I'm going to allow the mic and camera, and then we'll have two questions in the chat as well. Okay. Eva, can you unmute yourself?
I'm working on it. Can you? Yeah. Hi,
Yes.
Eva Kaminska, this University of Bremen. I'm working on the access to reproductive health services for Ukrainian refugees. I mean, this area has not been spoken about in the seminar today, but and I have a comment and a question regarding the multi-level governance within the EU. Because what is obvious is that Poland, that has been the recipient of so far most of the refugees, including Ukrainian women and girls that have suffered sexual violence in following the invasion. And these persons have not been able to access, for example, abortion services, for example, contraception in the receiving country like Poland. At the same time, Poland, of course, as a member of the European Union, is supposed to implement the temporary protection directive. And Poland itself did introduce, immediately after the invasion, once it was clear that there will be a massive inflow of refugees, its own laws that actually did give access to healthcare, but not to sexual and reproductive health services. So it is a question of accountability, and that's my comment, because obviously Poland so far has not been made accountable for the fact that scores of these persons, and we are talking about thousands of them, who have not received proper care. And here, footnotes, they have exclusively been able to rely on NGOs that had to take over the responsibility from the Polish state for that, or move to Germany or to the Netherlands to access abortion care. But there has been criticism coming from the European Commission and the FEM committee from within the European Parliament. But has there been actually any steps taken to effectively sanction Poland for not delivering? And the temporary protection directive speaks specifically about access to sexual and reproductive health, especially following sexual violence. So here there's an obvious lack of adequate implementation. So has there been any idea or an attempt from within, and maybe still subcutaneous, not officially formulated, attempt to really force the member states through sanctions to apply the temporary protection directive in an adequate manner, also in the area of sexual and reproductive rights?
Okay, yes, thank you very much for the question. Maybe really quickly, so that we can also take the last question from the chat. Apostolos, you have your hand up.
No, take the last question and we can reply to the answers.
Okay, yes. So the last from David, has there been a discussion at EU or national level with regard to the healthcare dimension of the proposed anti-migration deals with Egypt and Tunisia?
And there's one more hand up.
Oh yeah. Oh, okay. Yes. Right. Indeed. Allow mic. Sorry about that. I missed it. It didn't show up. Jalal, do you want to just really quickly ask your question, and then we can address, speakers can address three of them together then. I think you're still on mute.
Fine. Okay.
Hi.
Yeah, good afternoon to you all. I just wanted to thank you all for the important messages that you are giving to the community and policymakers regarding forced migrants and the need that, the community and also the public and policymakers should be aware of the need of these refugees and forced migrants. But the other point that I wanted to mention is that, as we all know, 75% of refugees and forced migrants are living in low and middle income countries, in the neighboring countries. And I think we should bring this into the attention of all the public and also policymakers. I mean, look at the refugees who are in Turkey. Close to 5 million Afghans are in Iran. Above 3 million Afghans are in Pakistan. 3 million or more Syrians and Afghans are in Turkey, in Jordan, in Lebanon. I mean, this is only in the Middle East, and then we have Sudan and then other places. I think in addition to the awareness that we are making about the need for healthcare and facilities to those who are living in Europe and Australia and other places, I think governments and the people should also know that there are others, and the majority who are living in other parts of the world, that should not be ignored. So that's my point. Thank you.
Thank you. Very, very good point. So can I ask maybe the speakers to respond to whichever points you want very quickly, because we're already over time, but please feel free to answer. Thank you.
Happy to start, if that's okay. So thanks so much for the questions and for the last comment that I would very much sign. But yeah, given the brevity of time, I will focus on the EU for the final 2 minutes. On the question of Poland, I think that's a super interesting case because it has become such a unique case in a sense within the EU, or almost unique together with other Central Eastern countries, considering the Polish healthcare system. So even Polish citizens, of course, have issues at times to access healthcare properly and often need to rely on private healthcare provision and healthcare providers, etc. And I mean, you will know, just to kind of give the audience kind of this as background knowledge. So against this backdrop, then to have the group of Ukrainian forced migrants plus forced migrants who are not Ukrainians, thus even further at the fringes, kind of puts strain on a system that is already perceived as not properly working, which I think makes this a very interesting case, and I think which is also the reason that, at least to my knowledge, there is no kind of sanctioning from the side of the EU. There are individual court cases, but there's no EU institution, to my knowledge, that has reacted to this officially, in some kind of officially implementing any kinds of sanctions against Poland on the basis of the Temporary Protection Directive. Also because then again, they would probably need to go much deeper into the healthcare rights and health rights of the Polish citizens and kind of start there. So this comes against the backdrop, and I think this is very interesting because this is so typical for forced migrants' healthcare access, that there are so many overlapping areas that are all in themselves problematic, and when they're put together, they just make the problem so much bigger. So yeah, I think again, Poland is a very, very interesting case. And to David's question, to my knowledge, health access doesn't play any role whatsoever. Yeah, it just isn't, to my knowledge, any issue in these agreements and these deals, but maybe the others know more there than I do.
Tamara, do you want to? Yeah, are we on mute? Yeah, no worries.
Yeah, I'll just say really quickly on the question about Poland. I just wanted to say that I think here, here is one of the main challenges with EU governance, because we know that the European Union and the European Commission doesn't have the implementation powers that the state has, which makes accountability and ensuring that this legislation is put into place as it should be. And I think that's, to me, is a key issue in sort of like from an institutionalist perspective, because yeah, it's very difficult to sanction if you don't know what's going on, or if your methods of sort of oversight are limited in that sense. And I think also, I mean, I don't know what the thinking is behind here, but I do know that there has generally in the history of the Common European Asylum System been a reticence from the Commission to actually sanction and to enforce infringements. And it's only recently that it's sort of started doing that since the crisis. And I think there is sort of an issue here around that. So yeah, that's all I kind of wanted to say to that. And to the point about from David, just quickly, I also don't know much about the healthcare specifically, whether it forms any sort of thinking or discussion on these externalization deals. But I do know that I think that the European Union would say that through their financial instruments in funding and building infrastructure and capacity in these countries, that this is about providing better healthcare and better access, so that they don't need to then come to the EU. So I think it might be used, but I think the rhetorical tool of healthcare is really just a justification to prevent them from coming. And then to the comment from Jalal, I would say absolutely. And I think that really shows this idea of crisis as a type of framing, when you sort of compare perhaps capacity between some wealthier EU countries and then these neighboring countries. And so that's why I agree with Apostolos' comment that this is really also about political will when we sort of look at that. But that's all I'm going to say.
Thank you very much.
Very quickly, just to close, Charlotte, first of all, we are not dealing with a refugee, neither migration crisis. We're dealing with a policy-made crisis and with a management crisis. The point of view is that Europe did very well and did show up that they could respond to a refugee crisis like they did with the Ukrainians. The point of view is that Europe is missing a strategic vision, is missing planning, and that I think the weakness and the nakedness that you can face with the refugee situation, that reflects also the way how they're dealing with their own citizens. So Europe is being more far away through the citizen is asking the citizen to take them care of themselves. So the government today, even in Greece, says you can take care of yourself. It's not my responsibility. You are adult now. So this is something that theoretically what we need to challenge the governments is how they're taking care of us, how we're taking care of our work and life and well-being. If I can see that my life, for example, in my country as an individual, have been decreasing, let's say, the quality of life on different aspects, that's something that it's my responsibility to shout about me and others. Last but not the least, it's important to mention that majority of the refugees and migrants are in other countries and not in Europe. But I think this is not necessary. We don't need to discuss the migration and refugee phenomena. We need to make them accountable why they're not offering service for the people. Because this idea it's diluting the discussion. No, but this is too much. This is also too much for it. No, I think we need to focus on that discussion. This discussion about there are 280 million, 100 million does not help. It does not. They're not concerned about it. It's not a matter issue of numbers. Even one single person arriving in Europe, he would be treated the same way. Thank you.
Thank you very much. Thank you so much to all three of you. Really sorry that we ran over time a little bit, but the discussion was really, really fascinating and insightful and very important. And I also wanted to thank the audience members for attending and for contributing with such thought-provoking comments. Just to let you know that the recording and a short summary will be available next week. And if you would like to be notified of future events and activities, then you can sign up to our mailing list or follow us on Twitter, and all the necessary information can be found on our website, EUHealthGov.org. Thank you so much again to everyone. Thank you.
Thank you, Charlotte.
Bye.
Bye.